Modeling lung epithelial defects in CDH using patient tracheal aspirate-derived airway progenitor cells. Every year, over 1,600 babies in the U.S. are diagnosed with congenital diaphragmatic hernia, or CDH, 600 of whom will not survive due to severe lung defects. CDH is characterized by a hole in the diaphragm, allowing the organs in the abdominal region to seep into the lung space, preventing the lung from expanding and contracting. Interestingly, however, after surgery, when the lungs are free or more open, have more space, because the organs are pushed down into the abdominal region, and when the diaphragm is closed up, the baby still has a lot of trouble breathing. We hypothesize that in addition to physical compression of the lung, there's also intrinsic lung defects that contribute to the lung phenotype seen in CDH babies. This is known as the two-hit hypothesis. Since CDH babies have trouble breathing, they usually require immediate intubation upon birth. While intubated, babies are frequently suctioned endotracheally as part of routine clinical care. As it's almost impossible to get fresh tissue from these babies during surgery, we have developed a robust technique to isolate and expand airway basal stem cells from suction tracheal aspirate. We can then expand these cells in growth medium for about 1 to 2 weeks or 14 days, and after expansion we can differentiate them in what's called an ALI culture, or air-liquid interface culture, where BSCs are plated on a transwell, and underneath there's ALI differentiation medium, so they can stratify into and differentiate into club cells, mucus-producing cells, and ciliated cells. We can then compare the differentiation capacity of preterm, term, and CDH lineages. Out of the 8 CDH basal cell lines that we have, we were able to differentiate 5. We have tried the other 3 separate times without success. And the 5 lines we were able to differentiate, we see consistent results, as seen on the right. This is a KRT5 marker, which is a basal stem cell and undifferentiated cell marker, and it's 100% in all CDH lines, compared to only 60% and 10% in the healthy term controls. Further, there seems to be a very low proportion of secretory club cells and mucus-producing cells in the preterm and CDH lines. Interestingly, we see a staggered ciliated cell layer compared to preterm and term lines in the CDH cells, indicating heterogeneity of the cell lines that we derive from CDH patients. Here, we propose that tracheal aspirate-derived BSCs serve as a novel source of surrogate cells with which to study, characterize, and therapeutically modulate the pathology of CDH lungs.